Good morning, sir. Uh, my case is a 58-year-old gentleman, farmer by occupation, resident of Meerut, Uttar Pradesh. He presented to us with chief complaints of difficulty in swallowing solids and semi-solids since past 6 months. He was apparently asymptomatic 6 months back when he developed a sensation of food sticking in the lower chest, which was after which he developed difficulty in swallowing solids, which was insidious in onset, and gradually it progressed to difficulty in swallowing semi-solids as well over next 2 months. He gave history of loss of appetite, loss of weight. He was apparently well 6 months back when he developed sensation of food sticking in the lower chest, after which he developed difficulty in swallowing solid food, which was insidious onset, and gradually it progressed to difficulty in swallowing semi-solids over next 2 months. He gave history of loss of weight. He lost around 10 kg in the last 6 months. There is no history of loss of appetite, and there is no history of reflex or regurgitation or nasopharyngeal aspiration. There is no history of neck swelling, gurgling sensation, gurgling sounds while swallowing. No history of difficulty in initiation of swallowing. There is no history of associated postural modification to facilitate food or in relation to the temperature of the food. No history of change in voice, coughing or choking or halitosis. There is no history of abdominal pain, distension, vomiting, distension, jaundice or hematemesis. There is no history of breathlessness or back or bony pain. No history of corrosive ingestion or chronic NSAID use. He has no comorbid illness. There is no history of prolonged medication intake. He has not undergone any surgery in the abdominal surgery in the past. There is no history of family history. There is no similar family history. And he is chronic alcoholic since 30 years and chronic smoker since 30 years. Though he has stopped alcohol intake and smoking 6 months back. His appetite is normal, his sleep cycle is normal, and bladder bowel habits are also normal. He takes mixed diet. In the treatment history part, he was evaluated for the same outside with upper GI endoscopy, and CT scan was done in September. And he has received treatment in the form of radiotherapy last of which was taken on 29th of October. And medication he was taking in the form of oral medication twice a day, which was continued till 8 days back. Post treatment, he was able to swallow solid food for 3 weeks, following which he again developed difficulty in swallowing solids and gradually progressed to semi-solids again. To summarize, 58-year-old gentleman, chronic smoker and alcoholic without any comorbidities, presented with 6 months history of progressive dysphagia from grade 1 to grade 4, with significant loss of weight without any history of bone pain, shortness of breath, abdominal distension, jaundice or GI bleed. He has received treatment in the form of radiation and oral medication, after which his dysphagia was resolved for a brief period, but again it has progressed to grade 4.
Yeah, so in such a case, usually there is no differential diagnosis, but still some examiners, for the sake of theoretical discussion, may ask you some questions which you should be ready to answer.
Yes,
so based on this history, what is your diagnosis?
So based on this history, this patient is having grade 4 dysphagia of malignant etiology.
Don't repeat again. When a question is asked, give a direct answer to the question. Don't repeat what you have already said.
Yeah. Yes, sir.
What is your diagnosis?
My diagnosis is most probably carcinoma esophagus or carcinoma GE junction, sir.
So at the end of history, it is better to say that I think, or my diagnosis or my assessment or my analysis is that this is malignant dysphagia. Okay. And then you can say it can be because of carcinoma of the esophagus. It can be carcinoma of the GE junction. And as was pointed out in an earlier session, I don't know whether it was JST or AIG session, that a carcinoma of the proximal stomach, which is involving the GE junction, can also cause dysphagia. But because the epicenter lies beyond 5 centimeter, it doesn't classify as a GE junction. So it could be carcinoma esophagus, it could be carcinoma GE junction, and it could be carcinoma of the proximal stomach. which is involving the G junction.
Yes.
Okay.
Yes.
Benign. Could it be benign?
Sir, considering the history, he has received radiation and oral medication.
Okay, if you exclude the treatment history, could it be benign?
Yes, sir, it could be benign, but more, sir, basically history is suggestive more towards malignant etiology because of
That we have
patient.
already discussed.
Yes,
That is your first diagnosis. Now I'm asking you, after the first diagnosis, could it be benign?
yes, sir. There can be remote possibility of motility disorder, sir. But it
So
started
again,
with but it started with the solid food, sir, not with liquids. He's
your
still.
answer should be your answer should be unlikely.
Yes, sir.
He's a middle-aged gentleman, short history of progressive dysphagia, which started with solids, has gone on to liquids. So it is unlikely to be benign. This history does not suggest benign. Go back to your negative history. Yes. What are the causes of benign dysphagia?
Sir, benign dysphagia can be oropharyngeal dysphagia or esophageal dysphagia, sir. In oropharyngeal dysphagia, patient can be having neurological disorder or muscular disorder, sir. Uh, Sir, there will be difficulty in initiation of food intake in oropharyngeal dysphagia, and patient will have symptoms of regurgitation, choking, nasopharyngeal aspiration.
I asked you only the causes. I asked you only the causes of benign. Just enumerate the causes of benign dysphagia. Then we will discuss them one by one.
Yes, sir. Oropharyngeal dysphagia can be because of sir, stroke, uh, brainstem disorders, sir, neural nerve paralysis of glossopharyngeal nerve injury, or patient can be having dysphagia lusoria due to vascular this thing, sir, vascular anomaly, sir. Uh,
Esophageal.
and in esophageal patient can have motility disorder, sir. In motility disorder can be because of eclesia cardia, diffuse esophageal spasm, nutcracker esophagus, or hypomotility disorder, sir, idiopathic hypomotility disorder, or can be because of benign tumors, can be leiomyoma or lipoma of esophagus, sir, can be because of esophageal web or rings, sir, can be because of esophagitis, uh, pill esophagitis, or eosinophilic esophagitis, or
So
infective.
esophagitis will cause dysphagia.
Sir,
What does
more,
esophagitis cause?
it will cause odynophagia.
Yeah. So what are the common causes of benign esophageal dysphagia? You said motility disorder. After that, is it lipoma or fibroma? How many cases have you seen?
Not,
What are the common benign esophageal dysphagias you have seen?
sir, corrosive dysphagia we have seen, sir.
Yeah, so it is motility disorder, corrosive and reflux
Yes,
causing peptic stricture. So your
peptic.
negative history should also be mentioned in that order. You have mentioned corrosive in the last. The metastatic history should come at the end. First, you should rule out in the negative history. First, you should rule out that it is not oropharyngeal dysphagia. Then you should rule out that it is not benign dysphagia. And then you should say that there is no metastatic history. The order of negative symptoms also should be in order of importance. Why did you ask this? No history of abdominal pain, distension, jaundice, and hematobasis.
Sir, I asked this thing just to rule out disseminated disease in the malignant cause, sir.
So peritoneal dissemination causes abdominal pain.
Sir, patient will have abdominal fullness.
It is fullness and distension because of ascites.
Yes, sir.
And why hematemesis is in this group? In this, how
Sir,
hematemesis relates to dissemination?
Sir, in advanced disease patient may be having liver metastasis. That could be the reason for this thing, sir. Or patient.
So liver metastasis will cause hematemesis. Hematemesis is because of the primary tumor.
Primary tumor, sir. Yes, sir.
So that should come in a separate line. No history of hematemesis or melena or symptoms of anemia. That is nothing to do with the dissemination.
Yes.
Why did you ask for jaundice?
Sir, patient can be having uh, extrahepatic biliary obstruction secondary to lymph nodal involvement that is compressing the bile duct, sir.
Yeah, so that's very important. As I have been saying again and again, jaundice is not a symptom of liver metastasis. Liver metastasis very, very rarely cause jaundice unless the entire parenchyma is replaced by multiple bilobar metastasis, or there is a large metastasis sitting at the biliary ductal confluence and causing a major duct biliary obstruction. So jaundice in upper GI or HPB, G junction is more likely because of nodes in the HDL, which are causing biliary obstruction. And in the practical exam, make it a habit that your answer should not exceed more than maximum 2 minutes. No examiner would wait to keep on listening to a speech delivered by you. So your answers have to be very short and brief and specific. Where do you think, why did you say out of these three, CA esophagus, CA G junction, and CA proximal stomach, which one is more likely?
Sir, most likely in Indian setup is CA esophagus, sir.
Where in the esophagus?
Sir, symptoms poorly correlates the location.
That is the explanation of the answer. Give the answer first. Where in the esophagus?
अरे तो सी esophagus वाला था ना साला मेरे को पता है.
So where in the esophagus?
Sir, mid or lower? Sir,
yes. Where is the food sticking?
Sir, food is sticking in the lower chest, so patient may be having
if the
mid and lower thoracic esophagus, sir.
Yeah, it is very unlikely that if the patient says that the food is sticking in the lower chest, that the lesion is in the cervical or upper thoracic.
Yes.
If the patient says food is sticking in the neck, then lesion can be anywhere.
Yes, sir.
The lesion can be below the site where the food is sticking, but it is usually not above where the patient says food is sticking. So if the patient says that he feels that the food is sticking in the lower chest, it is very likely that the lesion is in the lower esophagus or G junction or proximal stomach. But yes, you were right in saying that this is a very poor correlation. I think we'll move on. Yes.
Sir, on examination, patient is average built, alert, conscious, oriented to time, place, and person with ECOG performance status of 1. His BMI is 23.8 kilogram per meter square. On examination, there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Patient is well hydrated. Pulse rate is 84 per minute and BP of 132/76 mmHg in left arm supine position. A respiratory rate of 14 per minute and patient is afebrile. Breath holding time is 34 seconds. On oral cavity examination. Sorry, sir.
Good that you mentioned breath holding time in patients who have esophageal diseases, who are possibly going to have a thoracic exploration. It is important. Even otherwise, I think many examiners now want that in your general examination, especially for a major illness, for a major surgery being planned, you should talk about not only the nutritional and performance status, but their cardiopulmonary capacity. So it is good to ask in the history how many flights of stairs the patient can and breath holding time. And if you have any doubt, like he's a smoker, so all the more that it is important. Which lymph nodes you looked for? You said there is no lymphadenopathy.
Sir, on examination, I look for cervical lymphadenopathy, sir.
Which cervical?
Supraclavicular lymph node.
Only supraclavicular?
No, sir, all cervical lymph nodes, but specifically supraclavicular.
Yeah, so that's important. In a patient with malignant dysphagia, all cervical lymph nodes and bilateral cervical lymph nodes are important, as opposed to when you are talking of an abdominal malignancy, where it is usually only this left supraclavicular node which is important. If your differential diagnosis is going to include tuberculosis, then it is bilateral upper deep cervical, the jugulodigastric group of lymph nodes, which is important because they are the most commonly involved. If your differential diagnosis is going to include lymphoma, then all lymph nodes in the body, cervical, axillary, inguinal, hepatosplenomegaly, everything is important. So you should specifically say, once you say that, then I know that you know the importance of lymph nodes in this case. Okay.
Sir, in oral cavity examination, sir, oral hygiene is good. Adequate mouth opening is there. Nicotine stains were seen on teeth, and tongue movements are normal, and there are no mucosal lesions. Cervical examination, there was no palpable lymph nodes, sir. On abdominal inspection, abdomen is flat. There is no fullness. Umbilicus is central, inverted. No visible lump, scar, sinuses, or dilated veins, or pulsation or peristalsis. All quadrants moving correspondingly with respiration.
Sir, okay. Ask him to change.
All quadrants are moving correspondingly with respiration. Hernial orifices are intact with no visible cough impulse. No renal angle fullness was seen. On palpation, abdomen is soft, non-tender. There was no palpable lump. No organomegaly was palpable. Hernial orifices, no palpable cough impulse was observed. Renal angles were free. On percussion,
what lump you were trying to palpate?
Sorry, sir.
What lump you were looking for? What lump you were trying to palpate? You said no palpable lump.
Sir, in this case, mostly I would not be getting any lump, sir.
No. At your level, the examination is not a routine examination like an MBBS student. It is a targeted, specific examination. So what lump you were trying to look for? So it is a lump in the epigastrium, either a large proximal stomach growth or a large G junction growth or enlarged lymph nodes, especially if the patient is thin built, has poor musculature, it can be palpated. And therefore, in these patients, it is, and all patients where you are suspecting CS stomach, it is always a good practice to examine the patient in the sitting or standing position also, and ask him to take a deep breath and then palpate in the epigastrium, because the mass which is not palpable in the supine position may become palpable when you make the patient erect and ask him to take a deep breath.
Okay, sir.
Yes.
Sir, on percussion, there was no evidence of free fluid. Lever dullness was started. Lever dullness started in fifth intercostal space and mid clavicular line, and lever span was 13 centimeter in right mid clavicular line. Rest of the abdomen was tympanic. On auscultation, normal bowel sounds were heard. On digital rectal examination, there was no growth palpable, no Bloomer self nodule palpable, and finger stained with faces. There was no blood staining. On respiratory examination, trachea.
So as I have said earlier also, as far as I am concerned, it is okay if you say no free fluid, but many examiners would insist that your description of abdominal or any examination should be like a standard routine. So it is better to say that flanks are not dull, because no free fluid is an interpretation. It's not a sign.
Okay, sir. On respiratory examination, trachea is central. Bilateral respiratory movements are equal. Bilateral lung fields are resonant on percussion, and normal vesicular breath sounds heard. No added sounds were heard. CVS examination, S1, S2 heard. There was no murmur, and on CNS examination, there was no focal neurological deficit noticed.
What possible abnormalities could have been detected in the chest in this case?
Sir, patient is a non-smoker, sir. So he could be having crafts or onkai, sir. or patient may be having signs of aspirations and in the form of Krebs again, sir.
Yeah, so both. One, because of his chronic history of long-standing smoking, he could be having changes of COPD, which would mean uh, 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 pushing down of the liver dullness.
Yes, sir.
What is it called? क्या क्या बोलते हैं लंग जब expand होता है, there is
Overexpansion
a
of
term.
lungs in the emphysema, sir.
Hmm?
Sir, overexpansion of lung in the emphysematous changes.
Over expansion, and then you could have rhonchi, more important rhonchi, and
Rhonchi,
then
sir.
you could have crepitations, and you could have changes of pneumonitis because of aspiration, and you could have signs of pleural effusion, dull note, decreased breath sounds because of malignant pleural effusion.
Yes, sir.
Okay.
Sir, to summarize, sir, 58-year-old gentleman, chronic smoker and alcoholic without any comorbidities, with the history of 6 months progressive dysphagia from grade 1 to grade 4, with significant loss of weight. There was no history suggestive locally advanced disseminated disease, and he has received treatment in the form of radiation and oral medication. On examination, he is moderately nourished with ECOG performance status of 1, and his systemic examination findings are within normal limits, sir.
Gentleman, not gentlemen. MAN.
Sorry,
yes.
sir.
Next.
So my differentials are again the same, sir.
So based on the history, which one of these is more likely? Based on the treatment history?
Sir, based on the treatment history, CA esophagus is more likely, sir.
Why?
Sir, patient may be having, patient has received radiation along with chemotherapy, sir. So, carcinoma, and D junction carcinomas usually are adenocarcinomas, sir. So, where we are giving chemotherapy alone, sir.
Yes. Okay, carry on.
Sir, I would like to check for the previous record first of all, sir.
Yes, let's see.
Sir, he has undergone upper GI endoscopy and biopsy along with PET scan. He has received radiotherapy in the form of radiotherapy 40 gray over 20 fractions, last of which was taken on 29th of October. He has received oral capecitabine 1000 milligram twice a day, concurrent with radiotherapy, which was continued after radiotherapy as well. And he himself withheld oral capecitabine 8 days back, sir.
Do you think an endoscopic ultrasound should also have been done? That is the best investigation.
Sir, I would go for upper GI endoscopy and biopsy first instead of endoscopic ultrasound, sir. Though it helps in staging, sir. In endoscopic ultrasound would help in staging as well, sir.
Should have been done?
If facility is available, it should happen.
So what is the role of endoscopic ultrasound in CA esophagus?
Sir, endoscopic ultrasound, in case we are not able to prove biopsy, we are not able to prove biopsy, so we can go for an EOS guided biopsy, or it will help in staging, sir.
Is it a common situation that in CA esophagus you can't prove by upper GI endoscopy?
Not common.
What is the main indication, main use of endoscopic ultrasound in CA esophagus? Is it useful in early cases or advanced cases?
Useful in early cases, sir. Will know the depth of invasion, sir. And we can go for endoscopic mucosal resection and endoscopic.
So use of endoscopic ultrasound in CA esophagus is mainly in the early stages, where you want to know whether the disease is confined to the mucosa or muscularis and there is no lymph nodal involvement, so that you can avoid or you can obviate the need of neoadjuvant therapy. And very early cases, as you rightly said, whether the patient is suitable for endoscopic treatment in the form of endoscopic mucosal resection or endoscopic submucosal dissection. That is the only indication. A patient who presents with frank dysphagia is very unlikely to have early lesion, except when it is a polypoidal lesion, which is projecting into the lumen and that is causing dysphagia, but the depth of invasion is not much. So in our clinical practice, when patients present with grade 3, grade 4 or absolute dysphagia, endoscopic ultrasound has no use. In fact, you can't even do it because you will not be able, and the scope of endoscopic ultrasound is much bigger than the upper GI scope. So if there is dysphagia, it is very unlikely that you will be able to pass the scope through or beyond the growth, and therefore endoscopic ultrasound evaluation would remain incomplete. So for all practical purposes, in clinically diagnosed CA esophagus or suspected CA esophagus, endoscopic ultrasound has very limited role. The other place where endoscopic ultrasound may have a role, as you also rightly said, is when the mucosal biopsy is negative. So not only once negative, twice at least you have to attempt. And you think that the lesion is submucosal. If the lesion is submucosal, then an endoscopic ultrasound guided FNAC may get the tissue from underneath the mucosa and you can establish the diagnosis. So that would be the situation if you are thinking of a lymphoma, if you have a submucosal benign tumor like lipoma or a GIST. But all these findings will be very clearly seen on CT also. So endoscopic ultrasound has a role, but a limited role, at least in our clinical practice. Yes, let's see the reports.
And the upper GI endoscopy, which was done in September, showed ulceroproliferative growth occupying the almost 3/4 circumference, starting from 26 centimeter to 31 centimeter. Multiple biopsies were taken from the growth, and G junction was at 37 centimeter, and stomach and duodenum were normal, sir. So it was mid to lower thoracic esophageal growth, sir.
If you were doing the endoscopy, where will you take the biopsy from?
Sir, I would take 6 to 8 biopsies from the periphery of the lesion, sir.
Yeah, so at least 1 or 2 in each quadrant, and preferably at the periphery of the tumor where the normal mucosa is joining the tumor. That is where it is most likely to be positive.
Positive.
Okay, next.
Sir, on histopathological evaluation, it was found to be invasive squamous cell carcinoma, grade 1, sir.
Next.
Sir, then I would go for blood investigations and simultaneously routine investigation.
Yes.
Yes, sir. Sir, routine investigations showed hemoglobin of 13.7, and his albumin levels were normal, sir. He has albumin level of 3.8, sir. Rest of the routine investigations are normal, sir.
So say that in spite of a significant weight loss, he seems to be nutritionally
preserved, sir.
Yes. After that, what will you do? The next chest X-ray. What is the finding of chest X-ray?
Sir, this is a chest X-ray which was done recently, 2 days back only, sir. 3 days back only, sir. Which shows a normal bony window, sir, with the slight deviation of trachea towards the right side, sir, with the left dome of diaphragm slightly raised, sir, and bilateral lung fields shows prominent bronchomuscular markings. Also,
why the chest X-ray was done?
Sir, chest X-ray was done for dual purpose, sir. First for screening for dissemination of the disease, and as well as for assessment for COPD, sir.
Other than the dissemination, what features, what findings can we find in the chest X-ray?
Sir, this is a COPD case. Patient may be having emphysematous changes, sir, or
Okay.
yes, sir. Or patient may have signs of aspiration, sir, in the form of consolidation, sir.
Yeah.
And mediastinal lymphadenopathy we can also look at, sir.
Okay. And the further investigation next?
Sir, we did ultrasound abdomen, sir. Ultrasound abdomen.
What is the purpose of USG abdomen in this case?
Sir, USG abdomen was done to screen for dissemination only, sir.
Dissemination in the form, where will you find the dissemination? What will be the findings you will see in the ultrasound?
Sir, patient may be having a free fluid in the form of ascites, and patient may be having liver as well, sir.
Okay, one is liver as well. Other than liver as well,
sir, ascites, sir. Patient may be having ascites.
Okay. Okay. Maybe peritoneal deposit if they are large.
Peritoneal deposit if we can see.
If they are large only, more than 1 centimeter, maybe we can do that.
So some examiners may confront you that since this is a squamous cell carcinoma, are you anticipating or expecting liver metastasis to be present?
No, sir. Liver metastasis is more likely to be seen in adenocarcinoma, sir. Not in
So in squamous cell carcinoma, the role of ultrasound is mainly to look at the nodes, celiac nodes. And you can always answer saying that ultrasound is a simple, easy, inexpensive, non-invasive, easily available investigation. So there's no harm. Basically, the examiner is trying to ask you that why do ultrasound straight away go for a CT because you are not expecting anything, but you can always defend yourself. Yes. Next.
Sir, next I would go for CCT neck, thorax, and abdomen. But we have PET CT available with us, sir. He came with PET CT.
So what CT scan do you ask for in a patient with malignant dysphagia?
I would ask for CCT neck, abdomen, and thorax with oral and IV contrast, sir.
Yeah, so if you are thinking or if you are because by this time you already have a tissue diagnosis in adenocarcinoma, it is always better to include the pelvis also. But in squamous cell carcinoma, what you said is right, neck, chest, and abdomen. Okay, let's see.
Sir, this is CCT.
We don't see as yet.
Stop sharing and share again.
Okay, sir. Sir, is it visible, sir?
Yes, yes.
Sir, this is CCT head, neck, thorax, abdomen, and pelvis, sir.
So you said this is CCT. I didn't see any contrast in this. Is it there?
Non-contrasted, let's see. This is a non-contrasting. After that, we will then begin a contrasting. Let's see.
Okay. Next.
Uh,
So what would you like to comment on this, the plain non-contrast?
Sir, I would look for
Pulmonary lesion will be seen in this, isn't it? If there's any lung metastasis, it would be seen even in the plain cuts.
plain cut. Sir, in the I have this scan only, sir. Basically, that was done with PET CT. So I have this scan only, sir.
Yes.
Sir, as we can see, sir, esophagus is not distended. Oral contrast has not been given, sir. We are able to see some thickening from subcarinal level, sir. From here, sir. Which is going till this level, sir. Now the esophageal wall is again looking normal, sir. This lesion is abutting the left atrium, but fat planes looks maintained, sir. And it is some standing which is abutting the descending thoracic aorta as well, sir. Vertebral body seems to be free, sir.
How do you describe an esophageal lesion on CT scan? How do you describe the level? What landmark is used?
Sir, gyrus vein and inferior pulmonary vein are used as landmarks, sir. Sir,
First is the tracheal bifurcation. You say whether it is a supracarinal lesion or an infracarinal.
Infracarinal. This lesion is infracarinal, sir.
Because if it is supracarinal, then you are worried about the trachea.
Yes,
if it is infracarinal for a centimeter or so, you are still worried about the left bronchus.
Left bronchus,
but below that,
the
bronchi have separated. It is only the aorta which is important.
Yes, sir.
So show the relationship of the lesion to the left bronchus.
So here it is in close proximity, but trachea seems tracheal lumen seems to be smooth. There is no indentation, sir.
Yeah. So in patients who have lost weight, there may not be any fat between the growth and the left bronchus or trachea. So absence of fat plane does not necessarily mean that it is involved. The involvement will be only if there is indentation, irregularity, nodularity, change in the lumen from oval to concavo-convex, that instead of a convex lumen, it becomes a concave lumen. There is indentation or compression. So that is what indicates absence of fat plane here does not necessarily mean that it is involved.
Yes, sir.
Show the cut where the growth is in most close proximity to the aorta.
Around here. Around here, sir. Yes. Around here, sir.
Yeah. So what do you think? How will you describe this?
Sir, it is abutting, but fat planes looks maintained, sir, here as well, and angle of contact is much less than 90 degrees, sir.
Is less than 90 degrees, isn't it?
Yes, sir.
So if there is a fat plane or if the angle is less than 90 degrees, then aorta is
not involved, sir.
Unlikely to be involved.
Sir. Unlikely to be.
If it is 90 to 180 degree, then there is a suspicious involvement.
Yes.
And if it is more than 180 degree, then probably it is involved.
Involved, sir.
So one is tracheobronchial tree, other is aorta, which is the third structure which is important.
Sir, vertebral body, sir.
Vertebral body. Which are the structures which are not important, even if they are involved?
Sir, parietal pleura, parietal pericardium, peritoneum, diaphragm, or azygous vein, sir.
Yeah, diaphragm, including the crura, especially in the junction growth.
Yes, sir.
Can you show the crura of the diaphragm?
Yes, sir. Sir, this is the left crest of the diaphragm, sir. And this one is the right crest of the diaphragm, sir.
The two sheet-like structures in front of the aorta on the right and they are the crura of the diaphragm. Okay. What else you would like to show us on CT?
Sir, lymph nodal station, lymph nodal assessment, sir. I would like to see, sir. And
do we see any lymph nodes?
Yes, sir. Patient is having here, sir, paraesophageal and subcarinal lymph nodes are there, sir. Also, right paratracheal lymph nodes are there, sir.
Yeah, I think there are multiple small nodes.
Multiple small nodes are there, sir.
Anterior, posterior, to the right, subcarinal.
Also on the left side, sir, in left paratracheal region, sir. Also. This is also subcentimetric, sir. Yes, sir. And there is no significant lymphadenopathy in the neck, sir. Also, I will see upper abdominal lymph node, sir.
Yeah, actually, I forgot that many centers use ultrasound, not mainly for abdomen, but for neck to detect cervical nodes, enlarged cervical nodes. In many centers, that is a part of routine workup of a patient with malignant dysphagia to look at the cervical nodes.
Okay.
Anything in the abdomen, celiac?
Yes, sir. I'm looking at it, sir.
Show the celiac axis.
Sir, this one is the celiac trunk, sir.
Why is this not superior mesenteric?
Sir, it is dividing into splenic. This one, sir.
Yeah, you can see in one of these areas that it is dividing into
splenic and common hepatic, sir. This is splenic.
Yes.
And sir, it is going towards, this one is going towards.
So you have to be very careful when you say whether it is celiac or superior mesenteric, because there will hardly be a distance of a centimeter or even less between the origins of these two vessels. So a vessel which divides into two or three, usually you see only two branches, is the celiac, and the one which is below that, which doesn't immediately divide, but it just descends down as a trunk. And then the superior mesenteric also will have the superior mesenteric vein on its right side. So that is how you differentiate between celiac and superior mesenteric on the CT scan. Okay. The contrast phases, to show anything else, anything different? Otherwise, you can show us the PET.
Sir, I have this scan only, sir, basically, along with PET, sir.
Yes. So I think there were metastases in the brain because I saw a lot of FDG activity in the skull. Brain?
No, sir. There will be physiological uptake which is much higher compared to rest of the body in the brain, sir.
Yeah. Which other organs you will see normal physiological avidity?
Sir, in kidney, sir.
I think heart, kidney, and
urinary brain, sir. Yes, sir.
Yeah.
Sir, here we are able to appreciate some FDG uptake, sir, in this region, sir.
So these are some googly questions. I usually am not fond of throwing googlies, but many examiners are. So you have to be careful. that
Okay.
not all questions have a positive answer.
Yes, sir. Sir, there is some uptake around here, sir, but I'm not sure about this, sir.
There's nothing like around here. You have to say where. The anatomy. The
Sir,
description
around
of an image should be, the description of image should be such that even if I'm not looking the image, I know what you are talking about.
Yes, sir.
So this is, these are
Sir,
which area?
left gastric and celiac, sir.
Yeah, probably see around the celiac.
Around the celiac, sir.
Yes. Okay, show the report, PET CT report. So the advantage of doing a PET CT is that you, the point which we were discussing, whether you ask for neck, chest, abdomen, or include pelvis, because if you're doing a PET CT, then obviously everything will be included. Any reason why in the PET the legs are not included? It's usually up to the knee.
Usually up to mid thigh we are doing, sir.
Why?
Yes.
Because the bones
usually
below
the
that
lymphatic
usually not the
lymphatic
side.
drainage is, sorry, sir. Usually the lymphatic drainage is towards the via thoracic duct towards the left supraclavicular lymph node, sir.
No. In any PET scan, usually you don't see the area below the knee.
Yes.
Why? Because the bone metastases are usually confined to long bones only. It is very uncommon to find metastasis in the tibia, fibula, or the small bones. I think that is the reason why they don't usually include the legs.
Okay.
Okay, let's see the report.
Sir, there is FDG, avid short segment circumferential wall thickening in the lower esophagus, maximum thickness of around 1 centimeter, involving 3.6 centimeters.
No, we are not. Unshare and share your screen again. We are still seeing the image.
Okay, sir. Is it visible, sir?
Yes.
So there is FDG, avid short segment circumferential wall thickening in the lower esophagus with maximum thickness of around 1 centimeter, involving 3.6 centimeter of esophageal segment from D7 to D8 vertebral level with SUV max of 26.1. Mild FDG, avid subcentimetric lymph nodes around the perivascular, right paratracheal, subcarinal, and bilateral hilar lymph nodes, sir, with SUV max of
what is your interpretation of this PET CT report?
The patient is having nodal positive disease, sir, without evidence of dissemination, sir.
You think these nodes are positive?
Sir, can be reactive lymphadenopathy as well, because SUMX is grossly different as compared to primary lesion, sir.
How on CT or PET do you decide that the node is likely to be positive or negative? What are the criteria?
Sir, if there is heterogeneous enhancement more than 10 mm size, sir, sir, then it is more likely to be involved node, sir.
Any other size, enhancement, anything else?
Sir, loss of hilum, sir.
So size,
shape,
shape also. Normal nodes are homogeneously enhancing.
Yes, sir.
And they are oval in shape and their
round shape, sir.
Largest diameter is less than a centimeter.
Less than centimeter.
If the node is more than a centimeter, if it becomes round, from oval it becomes round, and if it shows heterogeneous enhancement, and on PET scan if it shows avidity, then it is likely to be positive. But both ways you can be wrong. Even a small oval node can be positive, and it is not necessary that a large round node is positive. So both ways it can be wrong. And that is why if you want to be sure about nodal involvement, you have to do an EUS guided FNAC.
FNAC,
So
sir.
that is important only if you don't want to give neoadjuvant treatment, because the condition where you don't want or you don't have to give neoadjuvant treatment is if it is
Node negative
T2,
disease.
T1 or T2 and node negative
Node
disease.
negative.
So if you want to prove that the node is negative, then probably you have to do EUS. Otherwise, you presume that it is like
Not
in this
possible.
case, there is a circumferential full thickness wall thickening. So it is likely to be at least T2 or T3 disease and nodes may be positive. Although here, I may say, what do you think? It could be T2N0 also, because I don't think these nodes are positive. They haven't mentioned the size, because one of the nodes I thought was at least a centimeter or more.
Yes, sir.
There was a big. So if that is so, and it was looking round also, so even if there is no avidity on CT, at least I would suspect that it is positive. Okay. Anything else?
So for now,
So what will be? Yeah. Do we have any other information? Otherwise, one last question I'll ask you.
No, sir.
Good that you mentioned the chest X-ray first. You should always mention chest X-ray. Go back to the chest X-ray.
Yes.
Is it normal?
Sir, right, sir, a bit of right division of the trachea is there, sir, and right dome of diaphragm is likely pushed because of emphysematous changes, sir.
But emphysema should be bilateral. Why should there be unilateral emphysema? It seems that the left dome is higher than the right.
Yes, sir.
CT normal.
CT is normal. CT is normal, sir.
Yeah. Okay. Yes. So what will be your plan of management of this patient when he came to you first time with these investigations?
Sir, patient has already received.
No. He came to you in September with these investigations.
Okay, sir.
How would you have managed him?
Sir, I would plan for neoadjuvant treatment of this patient, sir.
What is the indication of neoadjuvant treatment in this case?
Sir, patient is having likely T3 node positive disease, sir. So
can you say that it is T3?
Sir, it is involving so usually patients with the gross dysphagia are in the advanced stage, sir. First thing, on imaging also, it is involving the entire wall of the esophagus, sir. But it is not limited to submucosa, sir.
Yeah, so you are right that a patient who has clinical and high-grade dysphagia is likely to have advanced disease. That is number one. Number two, check with the radiologist, but I don't know whether it is possible to differentiate between T2 and T3 on CT scan. And third, yes, if we think that there is a large rounded node, then probably it is node positive.
Not positive.
So what neoadjuvant treatment?
Sir, I would go for cross protocol, sir, with the 41.4 gray radiotherapy over 5 weeks and paclitaxel and carboplatin, sir, over 5 weeks, sir.
But you said he has absolute or near absolute dysphagia and he has lost 10 kg weight. You think he will tolerate this neoadjuvant treatment?
Sir, patient is nutritionally preserved as his PMI is around 24, sir. So nutritionally he is preserved and functional status is also performance status is ECOG 1, sir. So he would be able to
suppose he was poorly nourished and he was almost kind of bedridden or moving with support.
Sir, then I will go for feeding excess first before going for neoadjuvant treatment, sir.
Sorry, say again.
Sir, I would go for feeding excess first before going for
What
neoadjuvant
feeding
treatment.
excess would you use?
Sir, if possible, I will go for gastric tube placement. And if it is not possible, then I would go for feeding exogenostomy, sir.
What about a stent?
Sir, stent has its own complications, sir. The possibility of tumor perforation, we may not be able to place the stent with this much of dysphagia, sir. But if we are planning for surgical intervention in future, so it will cause a lot of fibrosis along with the radiotherapy, sir. So that would be difficult in post-operative.
Why should stent cause fibrosis around the esophagus? Does it? I don't think so. Unless there is a micro perforation or a frank perforation. So uncomplicated stent placement should not cause any periesophageal. That is an option that you can dilate and place a stent if cost is not a consideration, because that gives the best palliation patient can swallow.
Sir,
okay.
Yes, sir, that is an option.
You want to ask anything? You want to ask anything?
No, sir.
Okay, so it's 10. We will close. Please send me a mail, all students, vkkapoor.india@gmail.com. Write esophagus in the subject of the mail. Okay?
Okay, sir. Thank you, sir.
Thank you. We will.
Rishikesh. AIIMS Rishikesh.
Acha. And all students, you should log in with your name. Don't log in with your phone. You should rename it. If you don't know, then ask somebody how to do it. Okay. Thank you. Thank you, Neeraj.
Thank you, sir.
Thank you very
Thank
much.
you, sir. Thank you.